We are going to talk about something very, very important, extremely in vogue these days. There's a lot of discussion on this. There's a lot of myths about this, and there's lot of patient interest in this topic. So that is what we're going to discuss. There's a lot of interest from the medical community also to try and understand what exactly is diabetes remission. Now, you would have heard this artist with other names, like some people call it diabetes reversal, some people hai ke diabetes chudwa denge, whatever name you want to give. The point is that the correct terminology to use is diabetes remission. So in this next half an hour, 40 minutes, we are going to discuss everything in detail there is to know about diabetes remission. I'll also tell you some personal perspectives as well as evidence-based perspective on this entire topic. And by end of this enter this lecture, I really hope that you would be well versed with the entire topic of diabetes remission, and then you will be able to give your patients a better feedback in terms of the questions which they ask about this very important topic. So let's start. So let's first start with what's in the name. Should you call it remission? Should you call it reverse? Or should you call it cure? Well, again, just a word here. We have this presentation uploaded on Gamma. Gamma is the new AI app for making presentations. So you can use this QR code to follow the presentation on Gamma as well, so that in case you miss out any point, you can go back and review that over there. Okay, so let's come back to the topic which we're discussing. What is in the name? Would you call it remission? Would you call it cure? Would you call it reversal? So first and foremost, diabetes cure is appropriately completely inappropriate term. Well, cure often means that the patient is absolutely normal, everything has gone, right? There is no chance of the disease ever coming back. So there is clearly no cure for type 2 diabetes or for any form of diabetes. However, the term which is interchangeably used, and a lot of people use this term colloquially also, is remission versus reversal. And the scientific community, the endocrine community, the diabetes community prefers to use the term remission instead of reversal, and we'll tell you why. Now, remission basically means that there is need for ongoing support to prevent the patient going to relapse. The corollary to this is what you see in oncology. I'll come to this in a few minutes. Also, it also means that there is a continued efforts required from the patient side, right? So there is continued changes in lifestyle which are required and continuous monitoring which is required. Reversal, however, means that the glucose levels have normalized, but there is no further support needed. So it means that the patient is completely off the radar, right? Patient does not need to visit a doctor, patient does not need to maintain any lifestyle measures, etc., which is not true, as you'll learn from this entire situation at the end of the presentation. This is rarely achievable. The reversal state does not happen in normal human beings with type 2 diabetes, right? It does not happen. So the correct terminology is to use is diabetes remission and not reversal or cure. Okay, so these are wrong terms to use. Now, let me give you two corollaries to this to understand this situation better. One is a very fundamental point, right? Think of it as a state of matter, right? So if you see water, in a liquid state it's water, in a solid state it's ice, in a gaseous state it's steam. So it changes from one state of matter to the other, right? So these states are, well, to some extent stable, but it can change depending on the temperature, depending on the situation. For example, if you have water in the solid state, which is ice, and if you allow it to melt, it goes back into the liquid state. Same thing happens with diabetes remission. And we're going to discuss this when we discuss the pathophysiology of why this happens. But what you have to understand is, when you are in a state of remission, you are in that state at that moment of time, but does not mean that that's the state which is permanent. Water does not remain permanently in ice state, does not remain permanently in steam state, does not remain in liquid state permanently. The state keeps changing. So the same way, a patient who is currently in diabetes remission need not remain in remission all the time. The patient who is in a full-blown diabetes need not remain in full-blown diabetes and can go back to remission. So this is very similar to what happens in cancer. So in cancer, a lot of cancers, there are cancers where you say that the patient is cured from cancer. But in a lot of cancers, especially hematological cancers, we often say patient is in remission. A patient has leukemia, you gave them chemotherapy, patient has now gone into remission from leukemia. That means that currently the patient is out of danger, but does not mean that the patient does not require regular monitoring, does not require regular cure, or in fact may require some sort of treatment also on a regular basis. But as of now, the patient is out of danger. In some state, maybe the situation can go back into a relapse, and when the patient goes into a relapse, the patient goes back into where the situation was already. So what you have to really see a patient with diabetes is like a cancer, where the patient is either in an active cancer state or is in a remission state, and from a remission state can go into relapse state. Same thing happens with diabetes. So that is something you have to really understand and really kind of take into account. So what exactly is diabetes remission? What is the definition of diabetes remission? Now, for the purpose of standardization, American Diabetes Association in 2021 consensus actually gave a very clear definition of diabetes remission. This is clear, this is a consensus, this has been agreed upon by all the specialists across the world. Now, by definition, diabetes remission means that there are three situations which has to be fulfilled. One is that the HbA1c should be less than 6.5%. This same situation should be maintained for 3 months. And if you talk about medications, and this is where the importance strikes, the patient should not be on any medication which is a glucose lowering pharmacotherapy. So this is the current definition of remission. So again I repeat, HbA1c should be less than 6.5%. The duration of this HbA1c less than 6.5 should be at least 3 months, and the patient should not be on any medication. Now you will ask me very interesting questions. For example, let's say my patient is on empagliflozin, which is being prescribed for heart failure. Now we all know that empagliflozin can be prescribed for heart failure, can also be prescribed for diabetes. Now patient on empagliflozin is having HbA1c of 6%, and he or she is maintaining this HbA1c of 6% since the last 3 months. Is the patient said to be in remission? Answer is no. So by definition, empagliflozin is still a glucose lowering medication, and because the patient is on a glucose lowering medication, even though the intended purpose is heart failure, though the patient is on this medication, the patient is not said to be in remission. So such patient would not be considered in remission. Okay, so that's a very important thing you have to understand, that the patient should not be on any medication that is considered a glucose lowering therapy, even though it is not intended for the purpose of glucose lowering. It is intended for some other purpose, but he or she should not be on those medications. And then and only then would you say that the patient is in remission. So like I said, the key components are HbA1c should be less than 6.5%. In certain situations, if you are not able to get the HbA1c, you can also use fasting blood plasma glucose as a corollary. And if the fasting plasma glucose is less than 126 milligram per deciliter, the same can be considered as an alternative if HbA1c is not reliable. Same thing, the target should be there. It should be there for at least 3 months, and patient should not be on any glucose lowering medication. Now, why this point again of remission really comes, that if the patient has maintained this situation, it does not, and I repeat, it does not mean that the patient does not have to see the doctor. It does not mean that the patient does not have to be screened for diabetes related complications. Now, what are the complications that we usually screen a patient with diabetes for? So we screen these patients for kidney involvement, that is with a urine albumin creat ratio. We screen this patient for diabetic retinopathy. We screen this patient for heart disease. So all these things have to be regular screen for. We often look at the foot, we often look for UTI, we often look for any other infection, right? So we often keep screening and keep monitoring these patients, keep monitoring these patients, and even if the patient is in a state of remission, the monitoring has to be continued. Okay, so that's a very important point. And remission does not mean that the patient, tata, goodbye, you don't ever see the patient again, patient does not have to see you again. That's not true. The patient has to see you, and you need to see the patient at a regular basis to prevent the patient from developing these complications. Now, let's come to this situation, and this is something very important, and this is what, now I often see a public discourse in social media about diabetes remission. People often talk about complete nonsense. I've seen people talk about things which they have no idea of what they're really speaking about, right? First, you have to understand that all types of diabetes cannot go into remission. Some types of diabetes can have remission, some cannot have remission. For example, there are certain types of diabetes which are naturally remitting. Like for example, if a patient is on a steroid, so patient is having a HbA1c which is, let's say, 6%, patient is in a pre-diabetic state, and you give this patient glucocorticoids or steroids, and the patient's blood sugar goes up. For example, we currently have a patient in ICU who is having a raised ICT. The patient had an HbA1c of 5.9%. Patient was given a dexamethasone. Patient's blood sugar went to 200. Right? So by definition, the patient is having diabetes or hyperglycemia. But is this permanent? No. So when you reduce the dose of dexamethasone, the patient's blood sugar can normalize. So any form of drug-induced diabetes or certain steroid-induced diabetes or glucocorticoid-induced diabetes can be naturally remitting, because once you stop this offending drug, the patient goes back into a state of normoglycemia. Second is gestational diabetes. We all know, by definition, gestational diabetes is when the pregnant lady develops hyperglycemia, but after delivery the blood sugar becomes normal, and that is often again a naturally remitting form of diabetes. And certain patients, as you had seen in the time of COVID, there are a lot of patients who develop very severe hyperglycemia during COVID because of the COVID virus and because of other reasons, including because of steroids and even remdesivir. So such patients were having what is known as hospital hyperglycemia. This is something which we see day in, day out in our hospitals as well. Hospital hyperglycemia, also known as stress hyperglycemia, is often transient and can often go back to a naturally remitting state after the patient is cured from whatever infection or whatever disease that the patient is having, and the patient goes back into a normal state. Again, the hyperglycemia can reverse. So these are all naturally remitting forms of diabetes, right, which are naturally seen in state, right. However, having said that, if a patient develops hyperglycemia after giving steroids, or a patient develops hyperglycemia during pregnancy, which is gestational diabetes, this is like a natural stress test for pancreas, and such patients sorry, I'm having a little bit of viral infection so pardon my cough. So this type of situation is a natural stress test for pancreas. Okay, so a patient who develops hyperglycemia after giving steroids is likely to develop diabetes in future. A patient who develops gestational diabetes is very likely to develop diabetes in future if she does not take care of her lifestyles at a later date. So if you identify a patient who develops hyperglycemia in this naturally remitting forms of diabetes, it's very important that you re-emphasize the lifestyle and again monitor this patient, because they are likely to develop diabetes in future. Then of course there are certain types of diabetes which can undergo remission. For example, type 2 diabetes, or diabetes that happen because of certain endocrine disorders. For example, patient has acromegaly and you have done the surgery, you have done the pituitary surgery, acromegaly is cured, the patient goes into remission. Patient has thyrotoxicosis, which has induced hyperglycemia, again that can go into remission. Pheochromocytoma also can cause hyperglycemia, again that can go into remission. Cushing syndrome can produce hyperglycemia, can go into remission. So these are all situations where the patient can go back into remission after the endocrine disorder has been cured. But there are certain forms of diabetes which cannot undergo remission as of now, as of what we understand in 2025. There is a lot of research going on to get a type 1 diabetes into remission, but as of now there is no data. Alright, there are just some emerging studies, but mostly there is no permanent remission from type 1 diabetes. So type 1 diabetes being an autoimmune disease, there is no remission, and a patient with type 1 diabetes requires lifelong insulin therapy. Whether the patient likes it or not, that's the reality. A lot of pancreatic diabetes, there are certain early forms of pancreatic diabetes which can undergo remission, but most cases generally no. So in most cases pancreatic diabetes does not undergo remission, and such patients again have to be kind of more or less permanent forms of diabetes. And then there are certain forms of monogenic diabetes, or MODI, which again may not undergo remission, and again these patients again will have permanent forms of diabetes. So these are all forms of diabetes which generally do not undergo remission and have to be monitored. As of 2025, we don't have much data about remission in these cases, and all we have is that these patients probably have permanent forms of diabetes. So even amongst type 2 diabetes, all patients are not likely to develop remission. There are certain patients who are more likely to develop remission, and there are certain patients who are less likely to develop remission. We'll discuss this. This is a very important thing, and we'll discuss this in more detail to identify patients who are more likely to develop remission. But generally speaking, and this has been from my experience, so this slide, completely consider this slide as an expert opinion rather than from any data. We are going to show you data at a later date, but from expert opinion point of view, what we are seeing is that young patient with good residual beta cell can go into remission. A patient who presents in a ketosis prone diabetes, so or what is known as a flat push diabetes. So such patients suddenly present with very severe very high blood sugar with forms of relative insulin deficiency, and then if you give them insulin, these patients the blood sugar improves and the patient can go into a state of a sort of a remission. Obese type 2 diabetic patients also tend to go and have a more likely to develop remission, and those with NFLD or fatty pancreas also can undergo remission. Having said that, a very interesting point, Now, type 1 diabetes also has a naturally remitting form of situation called, right, honeymoon period. Right? I'm sure you heard about this. So, a type 1 diabetes honeymoon phase, a type 1 diabetes also naturally sometimes goes into remission. Of course, this period is undefined. It can, the definition of remission requires at least 3 months of period. Honeymoon phase can last anywhere between few weeks to months, and I've seen a patient in years also in honeymoon phase. So honeymoon phase can happen. There could be a transient remission which can happen with type 1 diabetes, but again, this is not permanent, and this again patient goes back into the same situation which they have, right? So in the same light, there are certain type 2 diabetes patients who present in a more aggressive manner, who present with ketosis, who present with very severe hyperglycemia and relative insulin deficiency. And then once you treat them with insulin, they go into a state of a honeymoon phase type of situation. And this honeymoon phase in such patients, if they are careful, if they are able to maintain good glycemic control and monitor the lifestyle measures, these patients tend to remain in that situation for a long time. In fact, even I've seen patients for years together, these type of patients who maintain remission. I think this is the most important type of patients who actually are likely to develop remission, and these are the patients we really need to closely monitor. Then there are patients who have NAFLD or fatty pancreas, right? So these patients also, what I've observed is that if the fatty pancreas and the fatty liver reverses, again, if they reduce a lot of weight, such patients also are likely to go into remission. And in fact, if you talk about Roy Taylor's work, the direct study, most of the work has been done in such type of patients who tend to have ectopic fat and who tend to go into remission. Okay, so we have developed this small little mini application which can help you predict which patients are likely to develop remission. So we have called it a Mohan Taylor Lakhani, that's me, tool for diabetes remission. Please note certain caveats. This is not clinically validated. Okay, this is not a clinically validated tool. This is just a you can say an open source experiment, right? There is a QR code I've given. You can scan this QR code to see how this tool really works. If I can show the video. Yeah, so here's the video. So this is what the screen looks like, right? So here, in this situation, what you have to do is, you have to enter the patient's data. Just mind you, there are certain investigations you'll require in such patients. You'll require a lipid profile. You'll require to measure the waist circumference apart from the weight and height. And you also require to look at the patient's mixed meal stimulation test, where you have to do a C-peptide in fasting and C-peptide post-meal. Okay, so let's enter the patient's data. So this is a patient who is 40-year-old, HbA1c 7.5, the weight is 96 kg, height is 178, waist circumference, let's say, is, you have to enter this in centimeters, so let's say 100 centimeters. Triglyceride is this much, 258. Let's say HDL cholesterol is 42, and you take the C-peptides. Let's say C-peptide value is 2.3 fasting and it is 8.6 post-meal. So here it will check for the eligibility for remission. It calculates the BMI. It calculates the mixed meal score. Again, this is a not clinically validated score which is developed by us. And then it looks at whether type 1 diabetes is ruled out or not. So remember, type 1 does not go into remission. So we rule that out first. And then it says that it belongs into the cluster. Now there is a cluster classification which is done by Dr. Mohan. That's why we have named this tool after Dr. Mohan, right? So we looked at this cluster, and there are certain clusters which are likely to develop remission. So this patient goes into cluster 3, which is combined insulin resistance and insulin deficiency, and such patients are less likely to go into remission. So again, such patients are not going into remission, and this remission criteria is not met, right? However, if the patient is in a certain different cluster, the patient is likely to undergo remission, and hence, we have selected certain clusters again based on Dr. Mohan's data to show that which patients are likely to go into remission and which patients are not. Again, couple of things I'll just repeat. This is not a clinically validated tool. It's an experiment. It's an open source experiment. So if you want to contribute to this, please be my guest, and please feel free to contribute to this, and we'll be happy to kind of take your inputs. Secondly, this is mainly for newly diagnosed patients with diabetes, right? So this is a patient who is newly diagnosed and who is not on any treatment. So this is not for patients who are already having diabetes and established diabetes and on treatment for a long time. This is only for newly diagnosed patients with type 2 diabetes. So this is the remission tool which we have developed just to kind of give you a glimpse of what type of patients you should choose for diabetes remission. So just a few caveats here. The diabetes remission tool, one, it is only applicable for newly diagnosed patients with diabetes. Second caveat, which is of course equally important, which is that this is not clinically validated. Okay, so this is just an open source idea, and kind of, if anybody interested in developing this further, please feel free to do that, right? So that's the whole point. Okay, so this is the mini application which we kind of developed. You can scan the QR code and have a look at this, right? Moving on, there are other alternative definitions for diabetes remission. So this is Dr. Kalra's work, right? So Dr. Sanjay Kalra had given some alternative definitions which can be used for diabetes remission. So for example, he says metabolic remission. So metabolic remission is a situation where there is reversal of insulin secretory defect or insulin resistance. So if the patient had insulin deficiency, if that gets corrected, or if the patient has insulin resistance, that reduces, that is metabolic remission. He talked about clinical or partial remission, that is, you achieve an HbA1c below an individual set point. That can be considered a clinical remission or a partial remission. There could be biochemical or complete remission in which the HbA1c reaches the threshold value, which is actually HbA1c of less than 6.5%. And he talks about pharmacological remission, where there is absence of requirement of any drug therapy. So these are all alternative partial definitions for diabetes remission. So we of course go with the strict definition which we talked about in ADA's definition, but these are all alternative definitions which we can use. Then of course there are other people who have given some other forms of remission where they talked about the duration of remission. So they say transient remission when the normoglycemia persists for 3 to 6 months. They talk about short-term remission when it's between 6 months to 1 year. Long-term remission when the patient maintains remission for 1 to 5 years, and prolonged remission when the patient has remission for more than 5 years. So the duration also is now correlated with some sort of terminology which is used for these forms of remission. Now let's come to the very important area, that is the physiology of remission and how remission happens and why remission happens. Now since you are on the Netflix platform, I'll suggest that we had this talk on on a pathophysiology of diabetes, and I talked about a unifying theory for pathophysiology of diabetes. I think you might be able to find it on one of the older lectures on Netflix. Here we have discussed this particular concept in more detail, but I'm going to talk about it again here. So what you have to understand is very fundamentally and very importantly, right, that diabetes basically is in a state of like a balance. Okay, so it's like a a balance. Okay, so on one hand of the balance, on one side of the balance, you have insulin resistance, and on one side you have the insulin production. Okay, so you have insulin resistance and insulin production. So this is the balance in the equation, right? So all forms of diabetes, any form of diabetes, when the balance between insulin resistance and insulin production is mismatched, that is when that leads to hyperglycemia. For example, if you talk about type 1 diabetes, okay, so let's talk about type 1 diabetes first, right? Okay, so in type 1 diabetes, insulin resistance is not a problem. The problem is beta cell function. So because of autoimmune destruction of the pancreas, or the beta cells, the insulin is not produced enough. So because, again, see, insulin resistance, the insulin production, okay. Now insulin resistance is static, but insulin production has gone down. Because insulin production has gone down, there is a mismatch and there is type 1 diabetes. Then let's say same thing happens with pancreatic diabetes. So pancreatic diabetes, again, the insulin production and insulin resistance is initially matched. Now the patient undergoes pancreatitis, right, or has chronic pancreatitis, and the insulin production goes down. Insulin resistance may remain the same, slightly increase, and this misbalance, right, leads to pancreatic diabetes. What happens in type 2 diabetes? Now here, hear me out what happens, right? So let's say this is insulin resistance and this is insulin production. Initially what happens is the patient starts gaining weight and starts having increase of insulin resistance, right? So insulin resistance keeps increasing. Now what does the body do? To compensate for the increased insulin resistance, it starts producing more insulin. So it keeps maintaining a balance. So insulin resistance keeps increasing, insulin production keeps increasing to match the insulin resistance. Now this goes on for many years. This is the situation where the patient is in a metabolic syndrome, or patient is in a pre-diabetic state. These are typically patients who have HbA1c of 5.9, 6.1, right? And what is really happening here is, and these patients also have acanthosis nigricans, their triglyceride levels will be very high, they'll have fatty liver. So these are the patients where there is increased insulin resistance and there is increased insulin production to match the insulin resistance. Now these patients, these are the best thing, if you want to form any kind of long-term changes to the patient, this is the state where you should intervene, right? Where what you do is with lifestyle measures to reduce the insulin resistance, and then naturally that gives more rest to the beta cells, and also the insulin production also eventually stabilizes. So these patients have to be, taken to task much early, right? Even before the HbA1c goes above 6.5%. However, if this situation is not taken care of and this keeps increasing, there comes a situation where there comes a point where the insulin resistance is still high, but the insulin production is not able to match the insulin resistance, and that is where there is a relative beta cell dysfunction, and this progressively worsens, produces a vicious cycle because of the glucotoxicity, and this produces an imbalance. And that is when a type 2 diabetes patient is diagnosed with type 2 diabetes. Okay, so this is the fundamental point, right? Now, right at the time of diagnosis, remember, and this is a question which was often asked to us in endocrinology also, even type 2 diabetes is a disease of reduced insulin production by the beta cells. Even though insulin resistance is the primary pathophysiology, the pathophysiology that actually defines the disease is the beta cell production of insulin. So even in type 2 diabetes, at the time of diagnosis, the patient has lost about 60% of its ability to produce insulin. Now, the question is, what can you do? So again, if you are in a situation where you are in a negotiating situation, right, in a patient with type 2, okay, so let me just draw this for you. Okay, so in a type 2 diabetes, the insulin resistance is high, insulin production is not able to match up. So what you have to do is, you have to meet midway. You have to reduce insulin resistance and slightly increase insulin production as much as possible. Now, that is why early, right, a patient who is earlier in the phase of the disease is more likely to benefit. I'll exactly tell you why. So it is taken that insulin resistance has to be brought down, right? Now, let's say this is the equilibrium state. So you have to bring down insulin resistance. So the more work has to be done to reduce insulin resistance. But a lot of times what happens is, especially in early diagnosed diabetes, there are some residual beta cell function which can be salvaged. So, and this specifically what happens is, the patient initially when they present with glucotoxicity. Okay, so during glucotoxicity, there are some beta cells which are salvageable, which also get stunned, and this stunned beta cell cannot produce insulin as it should. So if you reduce the blood sugar, this salvageable beta cell, which comports very small amount of it, let's say 5 to 10% of beta cell, these beta cells can be salvaged and you can actually improve insulin production also. However, this situation is not possible for long-standing diabetes, right? So that's why a patient who is having diabetes for a long time, and typically I'll tell you, if it's more than 10 years, more than a decade, very unlikely that the patient is going to go under remission, because the beta cell production is so poor that you have to reduce insulin resistance very severely to really match the insulin production. So long-standing diabetes, more than 1 decade, it is very unlikely that the patient is likely to undergo remission. More than 5 years also, right, if the disease has been around, less likely, right? However, for a highly motivated patient, that is also possible. But more than a decade of diabetes, it's very unlikely that the patient is likely to undergo remission, because no matter how much insulin resistance you are going to do, the insulin production is so poor that you are never able to match that insulin resistance, right? So this is a very important physiological point you have to understand, that to bring the patient into the equilibrium state, you have to reduce the insulin resistance as much as possible, and in some cases you can salvage a little bit of insulin production, right, which you can leverage, especially early in the disease, right, and then you reach a equilibrium state, and this equilibrium state is when the patient goes into remission, right? Now the same thing was what Dr. Roy Taylor has very eloquently described in his twin cycle hypothesis, right? So this is the fundamental which he used in his primary research work, which is the DIRECT trial. In fact, the most respectable trial for diabetes remission is the DIRECT trial. We'll talk about the DIRECT trial in a few while. So what he said is, he said something very simple. He said that type 2 diabetes, and if you understand diabetes now, right, it's very important that you understand that type 2 diabetes, there are 2 cycles you have to understand, right? One is in the liver, other is in the pancreas. Okay, so type 2 diabetes is a disease of primarily liver and pancreas. Now, both cases there is ectopic fat which is deposited. Okay, so there is fat deposited in the pancreas and there is fat deposited in the liver. Now, the ectopic fat present in the liver produces central insulin resistance. Okay, The fat which is deposited in the pancreas leads to what is known as fatty pancreatic disease, which leads to reduced beta cell function. Right? So the beta cell function is reduced because of the fat in the pancreas. And hear this very carefully. So the ectopic fat in the liver produces central insulin resistance, and the fat in the pancreas leads to reduced beta cell function. So what you have to do? You have to reduce both these fats, right? You have to reduce the fat in both the liver and pancreas. So this is where he proposed the theory of the twin cycle. Okay. So what he said was something very simple. He said you have to reduce the fat in these two organs. Now, of course, this is a simplified, oversimplified version, because the fat, though primarily the liver fat is very important and pancreatic fat is very important, there is also fat in the muscles. Okay, there is ectopic fat in the muscle which leads to peripheral insulin resistance. There is adipocytes which also contributes, which is, there is a lot of contribution of that as well. Right? There is also fat which is present near the cardiac muscle, right, which is the pericardial fat, and you have the fat in the kidneys, right, the renal sinus fat. So all these fats contribute to insulin resistance. At the same time, they also contribute to the complications that you see with diabetes. There is visceral fat also. So all these fat ultimately contribute to the diabetes. However, the liver fat is something which is very important, because liver fat you can actually measure, right? Liver fat is something you can actually visualize, right? And hence liver fat is something which is very good to monitor. Now, how do you reduce this ectopic fat? So to reduce this ectopic fat, currently the only strategy is to reduce the fat overall. So overall you lead to weight reduction, you lead to fat reduction, and this overall reduction of fat reduces the fat in all the areas: fat in the liver, fat in the pancreas, fat in the muscles, fat in the adipocytes, all the fat which is there, it reduces. And because all this fat is reduced, ultimately the patient goes into a state of remission. So fundamentally for type 2 diabetes to undergo remission, there is only one strategy as of now. Let me put it in big words: weight loss. There is only one way in which you can undergo diabetes. There are a lot of people who will come and tell you fancy things. Don't listen to fancy things. Only one thing you have to understand: there is only one strategy that leads to diabetes remission in type 2 diabetes, and that is weight loss. If you reduce the weight, you reduce the pancreatic fat, which improves the beta cell function. You reduce the central insulin resistance by reducing the fat in the liver. You reduce the fat in the pancreas, reduce the fat in the liver. Completes the twin cycles of Dr. Roy. You also reduce the fat in the muscles, right? You also reduce the fat in the cardiac, reduces the cardiovascular risk, and reduces the fat in the kidney, also reducing the renal risk. So all these things ultimately is what leads to the diabetes remission, and also remission from diabetes related complications. Okay, so this is a very important fundamental thing. So then comes how you will achieve remission, and this is exactly what I told you. The main way is weight loss. So you can see in all these things, right, except for one which I'll discuss, all the first four strategies which I said is related to weight loss. So weight loss by lifestyle measures, weight loss by meal replacement. This is what was done in direct study. Weight loss with newer agents like GLP-1RA or other drugs. Weight loss with bariatric surgery. And one alternate strategy is early intensive insulin therapy. Right? This is something separate, so we'll discuss this in more detail separate. Right? But the first four strategies ultimately involve weight loss. Okay. So now weight loss leading to diabetes remission is not a new thing. Weight loss has led to remission of many other metabolic disorders which we all know very well. For example, PCOS. PCOS, it's very well known that modest weight loss about 2 to 5% improves menstrual irregularities and improves fertility outcomes. And often, if the patient has significant weight loss about 10%, the entire PCOS goes into remission. Okay, so this has already been established in other conditions like PCOS. Another condition where it is very well established is non-alcoholic fatty liver disease, right, where 7% weight loss leads to remission from fatty liver, right. Similarly, the same thing is now known with type 2 diabetes also. How much weight loss leads to remission differs, but generally speaking, if you take the data from Dr. Roy Taylor's study, Dr. Roy Taylor has shown that 10 to 15% weight loss ultimately leads to diabetes remission. So for diabetes remission, probably the safe point is to target 15% weight loss. And this 15% weight loss ultimately has direct correlation with remission. So the proven strategy for type 2 diabetes remission is weight loss. This has been clinically proven across multiple studies, including bariatric surgery, including other medications and other things, right? So what you should do, if you want to just target the metabolic improvements, look at 5 to 10% weight loss. But if you are then looking at more complications and want to reduce diabetes and reverse diabetes, as a lot of people call it, then you have to look at 10 to 15% weight loss. And 10 to 15% weight loss is the weight loss which you should target if you want to get away from all these complications. Now, of course, there could be individual variation. Some people will develop diabetes remission with a lower weight loss. Some people will require more weight loss. So there is a spectrum. However, having said that, if you see Roy Taylor's work, 15% generally leads to remission in 90% of the patient. So it's that amount of weight is probably good. However, of course, you have to understand that the duration of diabetes and the other factors also come into picture, and one size cannot fit all. So you have to, there will be, well, quite literally one size cannot fit all. So there is individual variation in this response. Okay, so this is the direct study. Let's look at some studies, right? So if you look at the direct study, so this is the most, I think, probably the fundamental study which brought the talk about diabetes remission into picture. So direct study was done in England, right, by Dr. Roy Taylor and his group. It was published in the Lancet, as I believe, and I think it was published in some aspects of it published in NEJM as well. So what they used was, basically, it was a meal replacement strategy, right? What they did was meal replacement, right? So it's not, a lot of people say that, oh, ye kar denge, wo kar denge. No, it was a meal replacement strategy. So they actually took a form of a liquid meal, right? Pre-prepared protein shakes. These protein shakes were given to the patient in place of the meals, and this meal replacement is what led to diabetes remission. Okay. So the key findings, right? The duration of the study, the initial trial was 2 years. They found that at 12 months, 46% of the intervention group achieved remission, and 36% at the end of 24 months maintained remission, right? So again, the remission criteria was 6.5% without anti-diabetes medication for 2 months. However, now the definition is changed to 3 months, but let's take this with a pinch of salt and say that, okay, 2-3 months is fine, right? So ultimately, whatever it is, that's fine. And as said earlier, weight loss was the main predictor of diabetes remission. Now, if you see the trial in more detail, what factors led to more remission? Most significant factor for remission was weight loss, and those who had more than 15 kgs of weight loss, which is again close to 15%, and 86% of these were who had more than 15 kg weight loss at remission. So like I said, 90%, 15% if you lose weight, 80 to 90% you are likely to develop remission. So weight loss was the strongest indicator in this direct study. There are certain baseline characteristics which of course were associated with remission. For example, fewer anti-diabetic medication, lower triglyceride and GGT levels. That means that these patients had lower liver fat. Okay, so those patients with lower liver fat actually had, this is an indirect marker of that, lower liver fat had better chance of remission. Better quality of life, people with less anxiety, depression were more likely to develop remission. Lower baseline HbA1c, which is needless to say, and at 12 months. So if they, in the initial 1 year, if they are able to, have better kind of reduction of HbA1c, they are more likely to go into remission. Remember, it's a 2-year trial. And older age and male sex had more likelihood of remission, which is again contrary to what we used to think, that younger patients are probably more likely, but there might be other factors also into play here. What factors had were negatively linked with remission? So early weight loss, positive and negative factors. So early weight loss led to more remission, and higher program attendance led to more remission. But use of antidepressant, patients with anxiety, higher triglyceride, GGT, some weight regain after weight loss, all these had more negative consequences, and these were less likely to be associated with remission. Now, after looking at Dr. Roy Taylor's study, NHS actually funded a program which is the NHS T2DR program for diabetes remission, and they have looked at a similar strategy for diabetes remission, and this is the detail. You can find the details of the same. Some early initial 12-month period, they actually found 27% of the patients with complete data who achieved remission, and 32% of the patients of program completers achieved remission. So they also found about 30% of patients achieving remission at 1 year. Now, so again, here they've used 3 months as a criteria. Okay. However, of course, this is again early. They are doing some follow-up studies, right? So probably need to see what really happens to these patients in future. Then of course there are studies done from India, and I think the only notable study which have looked at these things very scientifically is the company called Twin Health, which has looked at this digital twin technology for diabetes remission. It's a very simple thing they've done. Is make it sound very complex, but it's very simple. What they do is they take, put all variables and sensors for you, and then after the sensors and variables, they take certain data from that, and based on the data, so they'll ask you to wear an Apple Watch, they'll ask you to wear a CGM, they'll ask you to wear, a sleep apnea monitoring device. So all these things, their data they'll collect, and after this data, they'll create a twin model, digital twin model for you. And what they'll do is they'll see what interventions are going to work for your digital twin model. So that's the ultimate, idea. The good part is that they are looking at this scientifically rather than trying to just make money out, a quick buck out of it, which is good. It's an expensive program, but at least they are looking at from a scientific perspective. So what they found was, there were a lot of patients where they had 74% reduction in anti-diabetic medication use. However, remission was not that great. The use of anti-diabetics was more of a thing which they really looked at, which I think is again a little soft target, but fine. I mean, it's fine. They mainly looked at extraglycemic improvements also, which they saw, right? And they found that there was reduction in blood pressure, HSCRP, triglycerides, NAFLD scores also, which is again expected with any form of data which has undergone any form of weight loss. Bariatric surgery, this is published, the SOS Swedish obese study, right? Again, 76% were free from diabetic medications at 2 years, and 5 years also 69% maintained remission. Again, a lot of patients actually sustained remission. So bariatric surgery is a very well established strategy for weight loss and very well established strategy for diabetes remission also. So a lot of patients, provided of course they don't regain the weight, can develop and maintain diabetes remission, which makes it a very attractive option for bariatric surgery. So I think it has a potential. However, of course, it will depend on the type of surgery which is done and a lot of other factors also. So what were the factors in the Swedish studies which led to remission? Duration of diabetes, again shorter duration of diabetes had more remission. Patients not on insulin had more remission. Patient with lower HbA1c, higher C-peptide values, and lower leptin to fat mass had better likelihood of remissions. These are all the things that looked at. Of course, apart from the remission from diabetes, these patients also had reduction in microvascular as well as macrovascular complications, which makes it very attractive for the remission part. Now, let's look at a completely alternative strategy for diabetes remission. And this idea, basically, this has been done in India also, right? Long term back, there's a study from the senior Dr. Sahai who looked at this it was published in JAPI. But this concept primarily comes from China, right? And this Chinese concept is early intensive insulin therapy in newly diagnosed type 2 diabetes patients, which they say leads to some form of remission. Now, the idea here is very simple. And I think this is a very attractive option for Indian patients also, because from pathophysiological perspective, a lot of the Chinese patients are very similar to Indian patients from a diabetes perspective, from a metabolic perspective. So what they did was, so you take a newly diagnosed patient with diabetes and you start them on multiple doses of insulin, right? Straight away start them on insulin. And then what you do is gradually you reduce the, give it, in this study, what they did was they gave insulin for 2 to 3 weeks, and then they stopped the insulin and the patient went into remission. And some patient actually maintained remission for almost a year, right? So 51%, right, was the remission rate, right? And in fact, in some cases they use insulin pump, right? So with insulin pump, 51% remission. With insulin, multiple doses of insulin, 44% remission. And if you used oral anti-diabetics, there was 26% remission. So early intensive therapy led to diabetes remission, and that's why if you see any of my talks, I always say early intensive therapy is the best way to prevent long-term complication, right? And how was this maintained? And there was a meta-analysis separately done, which said that at 3 months, 66% remission. As the time increases, the remission rate reduces. But even at 24 months, so these patients were just given insulin infusion or insulin, pump for 2 weeks, and some of them actually maintained remission for almost 2 years. Now, here the fundamental concept, I told you that you have to meet in the middle, right? So you reduce the insulin resistance or you improve the beta cell function. And here, in most of the cases where you are losing weight, you are reducing insulin resistance. But this is a situation where you're actually salvaging the beta cell function. So what you're doing is, by giving insulin early, you are reducing the glucotoxicity, and by reducing the glucotoxicity, you are improving the beta cell function, and this improvement in the beta cell function ultimately is what carries the patient for almost 1 or 2 years in terms of remission. So it's a very attractive idea, right? Just 2 weeks of intensive therapy and your patient actually goes into a very good state for a long period of time, right? So there was improvement in HOMA beta, which is a marker of insulin production. Eventually, there was also reduction in insulin resistance, and the first phase insulin production was restored, and there was reduction in glucagon levels. So overall, there was significant improvement in the biological parameters also as far as the insulin therapy was concerned, right? What type of patients had remission? Shorter duration of diabetes. So again, patients with new onset of diabetes or early diabetes had more likely to develop remission. Again, patients with a better fasting plasma glucose. Higher BMI patients actually had more likely to develop remission. Early first phase insulin secretion and lower need for long-term insulin therapy ultimately led to better remission. So these were the people who were more likely to develop remission, right? So this is the early intensive insulin therapy, right? So these are all strategies which you can do in terms of remission, right? So I think in this comprehensive lecture, we first talked about the definition. Again, let me repeat, the definition of diabetes remission is when you have the HbA1c less than 6.5% for at least 3 months, and the patient should not be on any anti-diabetic medication or glucose lowering medication. Secondly, we talked about the pathophysiology and the physiology of diabetes remission, and where I talked about the balance between the insulin resistance and insulin production. And thirdly, we looked at the strategies for diabetes remission, where we looked at weight loss being the primary strategy for diabetes remission, and a weight loss of close to 15% or 15 kg, right, whichever is higher, is more likely to develop remission. Whether this is achieved by bariatric surgery or whether it is achieved by diet and lifestyle measures and meal replacement, it doesn't matter, but ultimately that is what kind of combines. And then alternate strategy is the early intensive insulin therapy, which is proposed from China, where they found that especially newly diagnosed patients with diabetes, early on if you give them insulin, the patient goes into a honeymoon state, which often lasts for about 1 to 2 years. So now let's look at the final few slides, where we'll talk about a summarized approach. And here, this is from now on, what you're going to see or what you're going to hear is mainly expert opinion, no clinic, no more science, more of my opinion, right, which I'm going to give. So what I said, and if you see the title, right, it was truth versus hype, right, but I've sort of re-christened the title to good, bad, and the ugly, right? So there are good aspects of this entire diabetes remission equation. There are bad aspects of it, and there are some really ugly aspects of it. Let's talk about the good aspect. I think it's very important that if the patient is motivated, I think most important thing is if you tell, and I remember even before the direct trial, even before I still have that poster on my OPD, that type 2 diabetes can undergo remission, please talk to your endocrinologist about it. Still, that same poster is still there, pasted on my OPD, right? It's still around. This was almost 5 to 7 years back when we talked about this, thought about this, and actually wrote about it. Now, the good part is that this is highly motivating for the patient. So if you tell the patient that, you show them the light at the end of the tunnel, tell them that if you are good at lifestyle measures, if you are regular at, the targets which we give you, you can stop the medications and you don't have to be on medications for the rest of your life. Secondly, again in terms of cost, and this is why NHS is really looking at this very closely, is that diabetes remission reduces the cost burden. Remember, the medication burden reduces, the complications reduce. So because complications reduce, the chances of, the risk, the cost burden because of the complications reduce. And very importantly, we are then focused on the core pathophysiology of the entire disease. Now, ultimately, we are looking at core pathophysiology, because earlier, when I was a MBBS student or a MD student, it was all about sulfonylurea, de do, ye de do, right? Which is completely wrong way of going about it. Now we have understand the basic pathophysiology, and now we actually deal with the pathophysiology because our patients tell us that I want to go into remission, and that's why give me drugs and give me medications which can change. And this is where, I have said this, we have said, I say a lot of things, unfortunately, don't publish all of these things, right? But we have used this terms disease modifying anti-diabetic drug, right? This terminology is basically what we are trying to say is that a patient, there are certain drugs like the SGLT2 inhibitors or like the GLP-1 receptor agonists, which modifies the disease process, and because of the modification of the disease process, this ultimately hits the core pathophysiology of type 2 diabetes and ultimately then leads to better long-term outcome. Don't take my word for it. This has widely been proven in multiple studies, right? So, I came up with this concept many years back, right? But I'm very happy that, the concept is now data is now catching up with some of these early ideas. The bad aspect of diabetes remission, and this is, I think, very important. Fundamentally, we forget that why are we treating this disease in the first place? We are not treating this to get patients rid of medications. That is not the aim. The aim is to prevent micro and macrovascular complications. Now, if the patient can prevent micro and macrovascular complications with the use of SGLT2 or with the use of GLP, why not? Why not consider giving them those drugs instead of just focusing on removing the drugs? So removing the drugs should not be the long-term aim. And this is what Dr. Kalra also said in his paper. The fundamental goal of diabetes remission should be to prevent long-term diabetes-related complications. I should not go away from the target. The target is to reduce complications and not to reduce medication. This is where I fundamentally differ with all these studies which were published, especially the twin health studies and all the studies, where they say, oh, we reduce the medication. No, reducing the medication is not the aim of any treatment. The aim of treatment is to reduce complications. And if you are able to prove to me that by your twin health or by any study, you are able to reduce the complications, which some of these studies and in their defense have shown, then it is an attractive idea, right? Again, you also have to prove to me that this reduction of the complications is better than existing gold standard, which are medical management. So if your therapy or if whatever innovation that you have done is able to reduce the risk of heart disease, able to reduce the risk of kidney disease, able to reduce the risk of other microvascular and macrovascular complication of diabetes more than the drugs which are available to the patient, like the SGLT2 inhibitors or the GLP-1 receptor agonists, then your therapy should be the gold standard and not these drugs. However, if your therapy is inferior to SGLT2 or a GLP-1, then SGLT2 and GLP-1 should be prescribed and not your therapy. And this is the fundamental thing you have to understand. If you do not understand this, I think this is where the problem really lies. And then comes the ugly. I have seen, I was going to, sometimes things make me so angry that I was actually going to put the screenshots of some of the really, bad commercials by certain companies about diabetes remission, diabetes reversal, and whatever nonsense, right? I beg of you, please do not refer your patients to any of these policies which are completely, I will not name them, I'll refrain myself from naming these, right, because the sanctity of the platform. But the point is that there are companies in India who are continuously misguiding the patient about diabetes remission. I have seen one ad, and I'll name the actor, is Boman Irani. I saw this completely ridiculous ad by Boman Irani regarding one company. Again, I'll not name the company, I'll name the ad, I'll tell you about the ad. In this ad, Boman Irani is sitting with a plate full of some very tasty food and a jar full of a glass full of what looks like a cola, and says that, oh, I can't eat this, I can't drink this, not anymore. You get into this program and then you are able to eat and drink this. Complete nonsense. Like I said, we started the entire talk from the very fundamental point that diabetes remission does not mean that the patient can eat whatever they want and can drink whatever they want. They cannot, because if they do that, remember, like I said, the ice can melt, the water can turn into steam. It doesn't take time for them to go back to the situation where they were. So there is no miracle cure. I have also seen ads where there is company who has said, oh, my HbA1c was 8.5, now it has become 7.6. My diabetes is reversed. What nonsense! That means you don't even know the definition of diabetes remission. So please, I request you, for the companies who are doing this, please stop doing it, right? And for the doctors who are there, and I think it's a high time that you push back on this. And then it's for the patients, again, please do not waste your money on this. Some of these programs are so expensive. It is a money well spent on other things, right? Please don't completely waste your money on these things which have absolutely no fundamental basis. Finally, some take-home messages. So, first take-home message is in the name. It's diabetes remission and not diabetes reversal. So second important take home message is that type 2 diabetes remission is possible in certain patients with type 2 diabetes. But what you have to do is you have to restore the balance between insulin resistance and insulin production. Thirdly, you have very well defined criteria for remission where we said HbA1c should be less than 6.5 for at least 3 months without glucose lowering medication. And we said that weight loss and early intensive insulin therapy are proven strategies for diabetes remission. And finally, we talked about the good, bad and the ugly. That is, the good part is that this actually motivates the patient to do well. The bad part is it often takes that, our target away from what actually we are trying to achieve. Ugly part is that there are clear push by some of these people, some of these companies to scam people, unsuspecting patients, and we should probably be refraining from that, right? And finally, it's an area of active research. There's a lot of scope for this in this area, and again, young researchers interested in this, I think, should be really taking this up as an area of research, because it is very important for the patients to really, from the patient's perspective, this is very, very important, right? So thank you for the patient listening, and now we'll be happy to take questions which are there.